you just take off your glasses for a second. First thing you're going to do is palpate the auricle, or it's referred to in some places as the pinna. So I do one at a time. I'm feeling for any lesions. The tragus that sticks out here, I manipulate it to see if there's any tenderness. I palpate the mastoid process behind the ear for any tenderness. I don't feel any lesions. Sometimes people have little lesions. Any tenderness when I do that? Okay. Then the next thing I'm going to do is just look visually the external ear to see if I see any discharge, any redness, and then I'll do my otoscopic exam. And I don't see any discharge, any redness with my eye. Now, because I'm looking in an adult ear, which position am I going to hold the auricle or pinna? Up and back. That straightens out the external canal, and I'm going to look there first for any cerumen. Okay. Her TM, tympanic membrane, is clear. There's no signs of bulging, retraction, or scarring. I'm looking at the cone of light, which comes off the umpa, which is in the center of the TM, and it's at around the 5 o'clock position.
May I say something? I think that we can't see what, as the professor who's evaluating you, we want to hear you saying those things. Did you say that?
Yeah.
No, I haven't said that.
Because
I said what I saw.
We're going to look at your technique, looking, with the way you're holding the otoscope, but we want to know what you're saying.
Okay.
Even if maybe you don't see it.
Well, if you don't see
I'm
it,
looking for
right,
the cone of light at 5 o'clock or 7 o'clock, so whichever year you're in. So I know, for me, I want to know that that's what you do.
and if for some people have a lot of cerumen and it blocks the TM, you can't see anything. Be honest about it. That's what you document. But if the ear was clean, I would be looking for the cone of light at around the 5 o'clock position in the right ear. And at the TM, I'm looking for color. It should be like a pearly gray color, because I know if it's red, there's inflammation there. If there's blue, there's blood behind it. I want to make sure the TM doesn't have any perforations or holes in it, no signs of scarring. And it's not bulging. Bulging means that there's fluid or pus behind it pushing it more in your direction. Notice I'm holding the otoscope up like this, not like this. Why? Well, there's a reason for it.
You don't want to hit the patient in the head.
Huh?
Follow the slope of the canal.
Well, no. It's so in case your patient moves, you're going to cause less trauma to the TM. Okay, if they move their head. If you're like this, you could go in even further. Okay, here we see a little cerumen, but it's not blocking the TM. The TM again is pearly gray. There's no scarring, no perforations, no bulging, and the cone of light is around 7 o'clock. Very good. You keep your ears nice and clean. Okay, then I could do the Weber and Renee, and before I do that, I could do the whisper test. I demonstrated that already, so I'm not going to do it again. With the Weber, you're looking for lateralization. The way I remember it is this looks like a W on the top of your head. So you ask your client, where do they hear the sound or the buzzing coming from?
It's equal on both sides.
Okay, you could point. But there's also air conditioning or some vent. I can hear that myself. So you have to be cognizant of the environment in which you're doing it.
Does it matter where you put that? Because I know in the book it says put it behind the cowlick, on the cowlick.
No, I usually do it right in the front here.
Oh.
And then make sure you're not holding it like this, because that'll stop the vibration. You want to hold it from the tip here. Next, I'm going to do the Renee or Rhine, whichever way you want to pronounce it. It compares bone versus air conduction. And what should be longer?
Air.
Okay, almost twice as long, but you don't have to have your watch to do it. Again, it's subjective. Let me know when the sound goes away.
No.
Okay, let me know when the sound goes away. So here.
No.
Let me know when the sound goes away.
No.
Okay, so you can see I would document AC greater, the greater sign, than BC bilaterally. Okay? So I would say to her, yeah, I don't see anything wrong. However you're cleaning your ears, continue to do that because it's good visualization. And we'll see you next year when you come. Thank you. See you in health assessment too.
There you go.
Okay, I think you have one that's, is it head, neck? Let's do that. Who will be, not the victim, who's willing to do, I have to get a cup for that one.